Good morning, everyone. It looks like most of the teams are here yet already, at least having some members in the room. And I want to be cognizant of the time, so we're going to get going, but do know that we're recording this session. So if you have someone who joins a little bit late, they can always go back and listen to this once the link is up. I know, Carrie, you had a parent who had some challenges, and I think it might be the same parent that I've been conversing with this week about the particular laptop they're using to connect. And we found out about that on Tuesday when she logged into the testing session, knowing that Chromebooks do not behave the same with Zoom as other computers do. So hopefully she can get on, and we will have her with us as we go forth. So welcome aboard. My name is Brenda Dietrich. I am a QI coach here at MHVI for the HFA programs funded by MDHHS, as well as some of the 32P sub-4 teams who are doing LAA-specific work. And I've coached some of the other teams in the past. I've been around for a while, and I also have done some projects on ACEs outside of home visiting in the past. So I was very excited to be given the opportunity to work with you all this year on our very first learning collaborative focused on ACEs resiliency. Can we move forward? Okay. Just some housekeeping things really quickly, same things as this morning. We want to hear from you, especially because this is a learning collaborative that is being run for the very first time. We are taking lots of learnings along the way. So any comments you have, absolutely chime in via the chat box or unmuting yourself. Haley has muted everyone upon entry, but if you want to speak, just unmute yourself and use the chat box. And once again, we are recording this session so that we can go back to it later. And I think we're going to skip these Zoom slides because Robin covered them this morning and you already did your annotating, and that's really all you need to have for this particular piece. So just a note here, again, I am Brenda Dietrich under the ACEs Resiliency. We have a cadre of staff who support the QI work here at MPHI. The Joy in Work is led by Angela Precht. ACEs Resiliency is led by myself, and then overall support is from our fearless leader, Robin Vandermoor, who is working behind the scenes and often in front of the scenes to coordinate this greater work. And then we have additional QI coaches in Grace Weatherby, Jeanette Ball, Shelley Kubstack. They all are here to support, and then Jordan, Paul, and Nick are here supporting our data pieces and our overall monthly updates for the Learning Collaborative. And then over in the corner, not to be forgotten, is Haley David. You've seen lots of emails from her. She is helping to coordinate a lot of our tech pieces and helping to run the sessions today. I wanted to also let you know that in the room here with me at MPHI is Julia Heaney, who is our program director and oversees the home visiting work here at MPHI, as well as Wendy Stafford from the state. And I didn't know, do either of you want to chime in with a little introduction? You good?
I'll just say good morning, everybody. So glad to be here. Always excited to kick these off and to learn alongside with you and see what we can discover in this new topic area, which I think is really very exciting for us here at MPHI.
And I'm just going to echo that. Good morning. I'm happy to be here with you. I will give you a heads up that I will slip out partway through because I have to cover 2 sessions today.
Thank you, Tiffany, for joining us for a little bit. I noticed a couple of teams having problems with sound in the chat box. Just make sure that your speakers are unmuted so that you can hear us. But other than that, we don't really have the ability to troubleshoot individual speaker challenges from here. So Becky, can you let us know when you can hear? It may help to log out and then log back in, there's a pop-up window that appears where you get to select the sound that you're using. It may help to log out, log back in to see that box, because once you make that selection when you're logging in, there's no chance once you're in the meeting to be able to change that choice. You actually have to go out and come back in. So that might be another thing that you can try. It's fixed? Woohoo! Great, Becky. I'm glad you're in and able to hear now. So our time together today, because this is very much a developmental collaborative and not so much like our standard learning collaboratives, because we are truly all learning together in this new piece, we wanted to take some time to take a pause and have a little bit of a centering kind of presentation about ACEs and resiliency, and some pieces Jody is going to talk about specific to Michigan data on ACEs. So we're going to have the opportunity to have Jody Spicer from MDHHS, who is the ACEs consultant within chronic diseases, but she is also previously a supervisor for a home visiting program here in Michigan. So she has a very comprehensive lens when it comes to understanding the challenges of home visiting programs in working on this ACEs journey with families and building resiliency. Then we're going to move into introduction of the ACEs Resiliency Change Package. Many of you were on the feedback webinar a few weeks ago and gave some feedback, which was put into the key driver diagram changes. We have some information about our measurement strategy, and then the team charter planning tool that will be used throughout the collaborative. I'm going to give you some information on a driver prioritization activity when your team is thinking about, goodness, which of these drivers do we need to focus on first, and some steps that you can use during your work time outside of the meeting time today to work with your team on deciding where you might work for this first cycle. And then some quick next steps on the uploading for group site, which will be the method for submitting your QI documents this year. Any final questions you have, and a note about how the evaluation will work following this virtual meeting. And then we have some time blocked on the agenda after 12:15 until 1 p.m. for you to have some team work session time. And during that time, you can completely log off with your team and meet at another time if that's what's most convenient for you, or you can stay on, mute yourselves, and I will stay in this Zoom room until 1 p.m. if you want to hop back on with any questions you have as you start to work on the driver prioritization activity or work on your team charter. It'll be kind of a live TA session that you can hop back on to access me directly until 1. So first up, we're going to open with this hopefully centering piece from Jody Spicer on understanding adverse childhood experiences and the power of resiliency. And again, Jody is the ACEs consultant at MDHHS and has been a prior home visiting supervisor and done home visiting work for several years here in Michigan. So we're going to hand this over to Jody. So give us some grace as we transfer presentations. Jody, we are seeing your presentation in the notes version. There you are. And have you started speaking? We can't hear you.
Sorry, I had to unmute. Can you hear me now?
We can hear you now. Can everyone hear Jody?
Awesome. I'm gonna go ahead and get started then and just assume that you all can see my title slide right now. Is that right, Brenda?
That is correct. We can see it.
Great. So thank you so much for having me be a part of your today's webinar and the Learning Collaborative around ACEs. Very excited about it. I've spoken with Brenda a number of times, and it's just awesome to be with my people again. As Brenda shared, I do have a long history and experience with home visiting, and most recently I'm here at the department working on ACEs, so this is a perfect fit. As Brenda said, the kind of the goal of my presentation is really to kind of ground us in the concepts of ACEs and understanding about the power of resilience. And I recognize that some of this may be review. Some of you may know this or a lot or a little, but I really find value in creating the shared meaning and common understanding so that we're all on the same page as we get started. So that's sort of the goal today. I also wanted to let folks know that I have kind of put everything up in a digital folder just for right now. So if you wanted to follow along or you want to reference the materials, I did put them in a Google folder for right now, but of course I'll share them with Brenda and the MHVI team so that they can turn around and share them all with you. So hopefully that's helpful for you, and I'll try to reference what is in that digital folder as I move forward. As I understand it, I have about 45 minutes, so we got started a little late, but I have a clock and a timer in here, so I'm gonna try to stay very cognizant of the time. I know you all have a very full agenda and lots of work to do, so I'm gonna try to move through the presentation, and I will, I have a hard time kind of doing that and monitoring the chat box, so I'm gonna just I'm going to keep presenting until someone like Brenda might stop me if there's a question. So if that works. And then of course, I'm always available after the webinar or in the future to answer any other questions or be additional support. So as Brenda shared, I'm here today as the MDHHS ACEs consultant. I'm also a master trainer with the Michigan ACE Initiative. And I've been in that role, I've been in the role here at the department for about 3 years. Prior to that, I worked in Ingham County. We had a Healthy Families program. Prior to that, I worked at the university, and I tell folks I sort of grew up in MSU Extension. So for the first 15 years of my career, I worked on campus with MSU Extension, and we had the Building Strong Families program. So I feel like this is kind of full circle, that we're kind of coming back together now and using our experience as home visitors and working with families and integrating what we know about the impact of early life experience, specifically trauma. I also want to just acknowledge that each of us brings to this work our own stories and our own histories. So, sorry, the lights keep turning off in this conference room. So I have 2 boys. Some of you have known me for quite some time, so believe it or not, Cameron is almost 20 and a sophomore in college, and Kai is a sophomore in high school. And so I bring to this work my experience as a parent, my experience also though as a daughter. So you'll see on the right, that's me in the lovely long pink dress. So I'm also a daughter and a sister and a cousin and have my own family history as well. And I think it's really important for us to acknowledge that the work that we're doing is not outside of that. So it's really important to sort of think about, as we approach this work, that we bring not only content knowledge and experience in home visiting, but we also have our own history and strengths and our own stories and experiences that kind of frame the work that we do. As we get started, I also want us to think about different perspectives. So I would invite you to kind of think about the parable of the blind man and the elephant. So as it goes, there was a group of blind men who encountered an elephant for the first time, and each of them touched different parts of the elephant. And not knowing what an elephant was, each of them sort of came to a different conclusion based on their own individual experience. So one of the blind men touched the elephant's side and said it felt like a wall. Another touched its leg and said it felt like a tree trunk. Another touched its ear and said it felt like a fan, or its trunk and said it felt like a spear. And the moral of the story here is that each blind man only touched a part of the elephant and didn't recognize or realize that it was just part of a larger story. They based their opinion on what an elephant was based on what their knowledge was. So the important thing here is to consider perspective. So encourage you to think about not just your perspective for this work or for the families that you work with, but also the perspective of the families that you work with, the perspective of your colleagues, the perspective of your family and your experience, and just sort of acknowledge that that adds layers to the work. So while we may see something one way, another person may see it a different way. And in doing this kind of work, it's really important to think about that as you do the work. So I sort of framed our discussion today. It's based on this model from Missouri and Oregon. And it's really kind of thinking about understanding about ACEs, understanding about trauma and resilience as a journey. And I talk to folks in my current role who say, we want to be trauma informed, or our agency or our program is looking to be trauma informed. And sometimes I think there's this understanding that all you have to do is take a training or get some learning and you'll immediately be trauma informed. And I like to think of it as a journey. And I think the learning collaborative experience and the QI experience lends itself to that. So today, what I'd like us to kind of just acknowledge is that we're really looking at, in my mind, ensuring that we're all kind of beginning this journey in the same place. So we're going to be looking at the beginning of the journey, which is becoming trauma aware and becoming trauma sensitive. So as you work in your program, in your agency, maybe even in your community, you may find that you're helping people become trauma aware. And so that's really focusing on understanding and recognizing, being aware of these concepts and these issues. And that's a great place to start. And then today, we're also going to begin to move into, and it's through this learning collaborative process, into phase 2, where we can become trauma sensitive. And the goal during phase 2 is gaining additional knowledge, assessing the readiness of your agency or your program, and developing process to support this work. I always tell folks, while I think food safety is important and probably more complicated than I understand, it's very different than learning food safety guidelines. So in my mind, if I learned food safety guidelines and I adhered to those guidelines, then I'm good to go. And I feel like understanding about trauma is an iterative process where we continue to learn, and when we learn more, we know better and do things differently, and it is a process. And so I think it's important to acknowledge and to recognize that we today are looking at phase 1 and 2, but my hope is that in our work together, or your work moving forward in the learning collaborative, you'll move a little further along on this journey. So let's kind of dive in. The first part of the presentation is really going to just focus on ACEs. I kind of want to break it down for everybody. I've had the opportunity to really take a deep dive into the role of early experience, specifically trauma and ACEs. And I just want to make sure that we're all understanding the same thing. So the purpose of this is to create some shared meaning and some common understanding. So what are ACEs and how do they relate to trauma and toxic stress? So this graphic that you see here is actually from a larger infographic on this, that comes from the Center on the Developing Child, and it is in the digital folder. And so I find that there's a couple that I'm going to share with you throughout the presentation. Sometimes I think they're really useful when talking to others, whether those are colleagues or professionals, sharing it with community members, and kind of helping to begin the conversation. So as I'm sure you know, ACEs actually stands for Adverse Childhood Experiences, and that's defined in the literature as a traumatic event that happens during childhood, and childhood is defined in the research as under the age of 18. I often say that because, as I shared earlier, I have a son who's almost 20, and he definitely considers himself an adult, and I definitely think he has a lot more to learn. So I understand that childhood, or that children don't fully mature by the age of 18, but because the study was retrospective, we asked adults to think about under their childhood, and that was defined as under the age of 18. The study actually identified 10 unique types of trauma, each of which counts as 1 point in an individual's ACE score. So to kind of pull back and do a higher level, the 3 types of ACEs that were identified kind of fall into 3 buckets. So there's abuse, neglect, and then a larger one known as household dysfunction. So for abuse, we're looking at physical, emotional, and sexual abuse. For neglect, we're looking at physical and emotional neglect. And then there's this larger bucket that is known as household dysfunction, and that's living in a family where there's mental illness, living in a family where there's an incarcerated relative, living in a family where the mother is being treated violently, so in the original study, it was looking at mothers being treated violently, but since then, it's been expanded to look at intimate partner violence. The 4th one is living in a family where there's substance abuse, and the last one is living in a family where there is parental separation or divorce. I think it's important to kind of acknowledge that these 10 ACEs were not where they started in the study. It's actually when they began looking at the data that was developed in the study that they found, I used to think these were the top 10, but really what they found is that these are the 10 that have the strongest correlation to negative outcomes in adulthood and represent prevention or the opportunity to do something about them. So I often like to pause here just for a moment and acknowledge a question that I hear quite often, and that is around parental separation and divorce. And sometimes folks ask if death of a parent is the same thing. And because I'm a master trainer with the Michigan ACE Initiative, I had the privilege of being trained by Dr. Anda, who is one of the co-investigators of the study. And we had quite a long conversation about this during the training, and he helped us understand that ACE, divorce or parental separation, came from a series of questions that were asked of adults that really were proxy measures for the kinds of things that happen when relationships kind of deteriorate in family systems. So they were questions like, did your parents argue with one another? Were your parents frequently not on the same page? Was one of them there or the other not there? And so think about the kinds of things that happen when parents separate or divorce. There were also some questions about loss of a parent through death. And what they found is that both of those have strong connections to negative outcomes. But of course, we really can't do much to buffer or impact death of a parent, aside from providing general health and wellness. And that the other thing that Dr. Anda kind of acknowledged is there are some, in many communities, there are socially acceptable supports available to families that have lost a loved one. And that isn't necessarily true when you think about parental separation and divorce. Oftentimes we're not aware of that, or it's complicated, or there aren't necessarily supports available for families. And so they're very different experiences. And so as Dr. Anda, who developed the questions in the survey, would say, these are the 10 ACEs that sort of rose to the top and represented things that we could do something about or prevention. That's not to say that there aren't other adverse experiences that have negative outcomes. Certainly the loss of a parent is a horrible experience for any child to go through, and there are negative outcomes, but it did not kind of rise to the top as one of the 10 original ACEs. So hopefully that makes sense. I just want to talk a little bit about the study. The link is here, and it's also in my references at the end. But just to help folks understand that this study was actually really unique because it kind of looked at how multiple forms of adversity or stressors have this outcome on for children and for adults. So from 95 to 97, there was a landmark study that was done by the Centers for Disease Control, which is where Dr. Andrew was working as an epidemiologist, and Kaiser Permanente, which is a healthcare system that Dr. Folletti was involved in Southern California. During this time, and even prior to the study, when you're a part of the Kaiser Health System, what you have to do is every year you have to have an annual exam, and prior to that annual exam, you have to answer a series of questions about your overall health and wellness. That's true, that was true in the 80s, 90s, and is even true today. From 95 to 97, Dr. Anda and Folletti had developed some additional questions about children's childhood, and they asked those folks that were part of the Kaiser Health System, would you be willing to answer some additional questions about your childhood? We're interested in kind of figuring out if there's a link between early adversity and negative outcomes. So there were about 26,000 people that were part of the Kaiser Health System during that time, and 17,000 of those 26,000 agreed to answer additional questions about their childhood. The other thing to note is it was much more than just 10 questions. It was more like 60 or 70 questions that folks answered about their childhood. The other thing to note is that participants were all members of the Kaiser Health Plan. The study was retrospective, so adults were reporting on what they experienced in their childhood. And because they were all insured and part of the health plan, they all obviously represented either working adults or living in a family with a working adult and having insurance. So who participated in the study? The study actually was done on this group of people. When they looked at the gender, it was a nice mix of male and female. But the audience was, or the study participants were primarily white. So you can see that 75% of them were white. So it was a very homogeneous group. So it was very, very white. You can see that the average age was a little bit older. It was actually 57. And you can see that the majority of them had education, so some college or college graduates. So I like to tell folks that the study was done on a mostly white, relatively educated, older group of people, so around 57. Their age was around 57. So it isn't necessarily indicative of individual communities. So as I travel around the state, people say, you know, this is really important data, but it doesn't reflect the community in which I live and work. And so we're continuing to gather data to broaden it. But because it was such a large study with 17,000 people, it was the largest of its kind, it's really stayed relevant and continued to be important when considering about the impact of life experience. So I want to kind of just give you some highlights about what the study found. I think there's 4 takeaway messages that I just want to make sure that folks are aware of and that they're able to kind of either digest or share with others. The first thing that the study found is that ACEs are common, but largely unrecognized. Now, I will say that we work in the home visiting space. You would maybe say, or I know I did when I was working in that space, that I did recognize them. I feel like I understood, even if it was just sort of an intuition, that experience did matter. But in the general public, and certainly in the clinical world, this was not something anyone had learned about, for instance, in medical school. So what they found in the original study was that almost 2/3 of the adults surveyed reported having at least one adverse childhood experience. So you can see that while 36% had 0 adverse experiences, those 10, you can see that 64% had at least one, and about 20% had 3 or 4. So when we look at how they break down, you can see here by ACE how they break down. So in the original study, the highest ACE reported was physical, 28% physical abuse. 28% reported being physically abused as a child. The next one was living in a household with substance abuse. And then the next one was living in a household with parental separation or divorce. The one thing to note here is that when we think about the impact of ACEs or trauma, it doesn't really matter which ACE it is. What matters is the load. However, once we know more about somebody and their experience, then that will help us work with that family. But when you think about the connection between early adversity and negative health outcomes, it doesn't really, the individual ACE doesn't matter. What matters is the combined score or the load. So in looking at the original ACE study, they did develop what's known as an ACE score. So looking at the effect of multiple stressors. And you can see this is just another way of looking at the data in terms of ACE scores. So there were, a third of them, a third of those in the original study didn't have any ACEs, but then you can see 2/3 of them had at least one, with many of them having 3 or 4. So the first thing is that ACEs are common, and in clinical settings, not something that people necessarily learned about. The second thing to know is that ACEs rarely occur in isolation. And this is, to me, where I was like, that makes sense, right, in my work with families. They tend to be highly interrelated. They tend to occur in clusters. And what the data found is that when there is one ACE present, there's an 87% chance of at least one other ACE and a 50% chance of a third ACE. So thinking about the ACEs again, that makes sense, right? So when I was working with families, or when I think about my own family or families that I care about, it's not too hard of a stretch to recognize that if I live in a household where there's mental illness or substance abuse, there might also be emotional abuse or physical neglect. Or think about families that you work with and how these kind of coexist together. And the data actually certainly shared that. The reason that's important, the third takeaway message, is that there's this dose response. So what that means is that the higher a person's ACE score, or as a person's ACE score goes up, their risk for developing negative health and well-being outcomes also goes up. So when, you'll look here, even if a person has 0 ACEs, they still potentially have a risk for negative health outcomes. There are other things at play, right? But you'll see that as their level of trauma or early adversity goes up, their risk also goes up. And that's known as a dose response. I just wanted to share some data from physical health and mental health to kind of show how they came to that conclusion. So this is from the original research, the original journal article, and it's looking at a set of chronic diseases. I sit in the division of chronic disease and injury control, and so I like to help folks understand that it really matters. What happens early in life does have outcomes later in life around physical health. So it's looking, we can see here, we looked at heart disease, stroke, COPD, diabetes, and STDs. And while it isn't necessarily linear like the previous slide, you do see, and I think the important thing to note is the difference between those with 0 ACEs and those with 3 or 4. So the green bars on the far right, every single one of these health outcomes, when you have a higher ACE score, like 3 or 4, it's markedly higher than if you had a score of 0 or 1. And that's the thing to sort of look at, is sort of the way it kind of moves across. Also, because we know the body is one and doesn't necessarily distinguish between physical health and mental health, they looked at mental health outcomes. This was done not in the original study, but about 10 years ago. And they looked at the prevalence of a variety of mental health outcomes. So mood disorders, anxiety disorders, substance abuse, and impulse control disorders. And then they compared that to a person's ACE score. So the red bar represents those with 0 ACEs and the green bar represents those with 4 or more. And you can see here that that impact of the early adversity or the ACE score is even higher when considering mental health outcomes. And ultimately, I'm going to just say that this is probably the hardest slide to see today. But ultimately, what we've learned through the original study and follow-up research is that people who have 6 or more ACEs tended to live 20 years less than those with 0 ACEs. So I'd like to just pause here for a moment and make sure that folks hear that correctly. This does not mean, because this is where folks like begin to sit while listening to this, think about their own ACE score or the ACE score of folks that they care about or work with or know. This is not saying that if this, then that. So this is absolutely not saying if you have an ACE score of 4, 5, 6, you are going to die 20 years sooner. That is not what this is saying. Instead, the research, the data, the study looked at age of adults in the study and ACE score. And what they found is that many of the adults who had an ACE score of 6 or more had lived less than their counterparts with 0. And we'll talk about that in a little bit. I did want to just acknowledge that since that original study was done in Southern California in the 90s, many states have been collecting ACEs data. So this comes from the Centers for Disease Control. You can see that in 2009, so about 10 years ago, there were a set of states that began collecting data. Here in Michigan, we began collecting data in 2013 and 2016. And then again, we did it in 2019. The way that states have done that primarily is through the Behavioral Risk Factors Surveillance Survey. That's an annual telephone survey that's done. It's done in every state. It's a collaboration between the CDC and the state health department. So here in Michigan, it's within MDHHS, and it's a telephone survey, and it's a sample that represents the state as a whole. So in 2013 and in 2016, we have state level data, and I'm going to share data from 2016 that will tell us what we know about adults in Michigan through the Behavioral Risk Factor Survey. So there is in the digital folder an infographic and an executive summary that is hot off the press. You're among the first to actually have the final copy. So a lot of this data is shared there if you're interested. But what we found, so the most recent data we have is 2016. I told you that we asked on our BRFS a set of ACEs questions from the CDC. We asked those in 13 and 16. We also asked them in 19. We don't have that data yet. So the most recent data we have is from 2016. And what we found is that in Michigan, there were 1.14 million people who were sexually abused or reported being sexually abused 1 or more times as a child. I often think like, well, what does that mean, right? And so when you think about it, that's enough to fill nearly 11 U of M football stadiums. So clearly that's a lot of people. We also found that 2.74 million people reported being verbally abused 1 or more times as a child. That's enough to fill almost twice, more than twice as many, so 26 U of M football stadiums. Again, a large number. So thinking about prevalence and ACEs in general, what we found in Michigan is that 34% of Michigan adults reported having 0 ACEs, 23% reported having 1 ACE, 25% reported having 2 or 3 ACEs, and 18% reported having 4 or more ACEs. So when you think about that, what does that really mean? So to me, the take-home message is that ACEs actually remain common in our population, and even here in Michigan in 2016. So in the lower right side, you'll see the data from the original study, which was done in California in the 90s. Remember I said 2/3 of adults had at least 1 ACE. You'll see here that it's really quite striking how comparable the data in Michigan is 20 years later. So what we know here in Michigan is that in 2016, 34% reported having 0 ACEs and 66% reported having at least 1. That data is very similar to the original data. To me, that's really important to think about. And I hope that you'll think about this in your learning collaborative. And in talking with Brenda, I know some of you heard a speaker at last summer's home visiting conference. I think it's important to understand about ACEs and understand about the impact of ACEs, But I also think it's important to understand that it's going to take time and concerted effort before we're going to be able to actually reduce the prevalence of ACEs. Because I work with adults in my experience and here at the department, I like to help folks understand that we all of us on this webinar today, all of us in this learning collaborative have an ACE score. That's not going to change. And so I don't think that's where the focus needs to lie. I do think it's important to understand the impact of that, but the focus in working with folks and with families and parents and in community is to understand that ACE's prevalence is a 2-generational or more kind of thing that's going to take a lot of time and effort to actually see these rates go down. I do think they'll go down, but instead we need to focus on how can we buffer the negative health outcomes and how can we help folks understand that these early experiences, while they are contributing to negative health outcomes, they are also creating a lot of resilience and a lot of wonderful skills in adults that are making it in this world. And I know that's a lot of what you all talked about in the summer in the ACEs and Resiliency session that was done by the groups in the by the group from the domestic violence world. So I just wanted to kind of wrap this part up and just make sure that we all are kind of aware that ACEs are common. They tend to have, they tend to coexist, right? So if there's one ACE, there tends to be a second ACE and a third ACE. There is this dose response. So the higher an ACE score, the higher the likelihood of also having some negative health outcomes. And then also acknowledging that these negative health outcomes have lasting effects, right? So these negative health outcomes are affecting our health. So they're affecting obesity rates, diabetes, suicide, STDs, heart disease, cancer, stroke, injuries. But they're also affecting behaviors like smoking and alcoholism and drug use, and ultimately life potential. So there's additional data that looks at graduation rates and academic achievement rates and even worker performance. So how folks work and their, the amount of time that's lost from work because of the effects of these early experiences. The important thing to note about ACEs, as I shared a little earlier, is that it has a cumulative effect. So the higher an ACE score, the higher the likelihood of these negative outcomes, but that's because of the load or the wear and tear on our body, which grows over time when an individual is exposed to repeated or chronic stress. It's also known as an allostatic load, but I like to think of it as literally changing the physiology of our bodies. And so there isn't much that as a child we can do about this. So if I'm a child who is in an environment where there's repeated chronic stress, I'm going to be affected by that, not only emotionally or mentally, but physically, because of this cumulative effect, which I'll talk about in a moment. I'd like to stop here for a moment and just acknowledge that there is something known as the ACE pyramid, and I could talk for hours about this, and I'm not going to today, but I'm happy to follow up with folks who may want to know a little bit more. I just want to kind of help explain why this happens, right? So why are these things connected? So the original ACE pyramid started with ACE at the bottom, and the newest form of this pyramid includes a bottom rung, which is labeled here, historical trauma and intergenerational adversity. The reason I think it's important, and I'm grateful that the perspective was a bit broadened, is that ACEs is an individual experience. So every one of us has our own individual ACE score, and actually individuals in families have different ACE scores. But we know through research and through our experience that there are things that happen to large groups of people that also have huge impacts on outcomes. So when we think about historical trauma or intergenerational adversity, we think about those larger root causes. We think about racism, sexism, classism. We think about differences in community assets. We think about differences in access to social determinants like transportation, affordable housing, quality childcare, access to the medical community. Those are things that happen to large groups of people, and those have a huge impact on outcomes. And so acknowledging that it isn't just ACEs. I once had someone say to me, well, there's nothing special about ACEs. And while I think there is, because my work obviously surrounds that, I will acknowledge that there are many things at play, and ACEs is just one. So I want to just make sure that we can contextualize that. And I think you see that in home visits for sure. I also then want to be able to say that once we kind of acknowledge that, right, that we have this larger perspective that we all live in, there are ACEs that also have this huge perspective, this huge impact. So you'll see here that this is a whole life perspective. And so ACEs are things that happen in our childhood. That's not to say that if trauma happens later in life, it isn't still very devastating, but it has the biggest impact in early childhood. And that's because of the developing brain and the neurodevelopment that's happening in our brains and the way that our genes are learning to be expressed. So that's known as epigenetics. So in early childhood, when we're exposed to chronic repeated trauma and stress, it actually changes the way our brain is forming, the way the connections are made, and the way our genes are expressed. And all of that's happening without anyone necessarily knowing that. And so when I think about a child who's had repeated exposure or has a high ACE score or has, any of those ACEs that we know about, I think about how they may interact in this world. They may be at heightened alert. They often have high levels of cortisol, which is the stress hormone. They may always be wondering whether it's a safe place or space in which they're living. And because of that, that's changing the chemistry and the physiological part of their brain. And because the brain is the central processing for the body, it affects our entire body. So thinking about children who are experience or have these adverse experiences, think about then how they grow and develop. And we learn and we know that they socially, emotionally, and cognitively function differently in this world. That doesn't mean it's bad necessarily, but it's different. So if I'm on high alert, if I'm always wondering whether my area, my space, my place is safe, I'm going to live, work, and play differently in this world, socially, emotionally, and cognitively. What the research has found over time is that oftentimes young adults and adults actually adopt or create coping strategies or adaptations that help them cope. So we learned that young people may decide that, oh, when I eat, I feel comfort, or when I smoke or vape, it helps calm me down. When I drink alcohol, that kind of mutes the heightened feeling that I have. And so these health risk behaviors in the clinical world, that's what they're known as, really think of them as adaptations, but they of course create disease, disability, and social problems, and those are the things that often lead to early death. The reason I like to share the pyramid is I think that we all have the opportunity to be really powerful agents of change or help folks understand that it isn't necessarily if this, then that, nor is it any one person's fault. But when you begin to understand why these things are connected, you know better, you do better. And so I encourage us to think about shifting away from what's wrong with you. Why do you keep doing these same things over and over? Or why do you continue to engage in these negative health behaviors? And instead begin to think about, which I think we do often in home visiting, let's kind of think about what's happened in your world and what's happened to you. I know I did that when I was working in healthy families. We did that in our parent survey. We really spent a lot of time trying to learn about families and understanding what's happened to them. This comes from the Center on the Developing Child, and I just want to acknowledge that while we're talking about ACEs and trauma, that really is in this red zone of this continuum. That's kind of toxic stress, this extreme, frequent, or extended exposure to stress that activates a person's stress response. There are things like positive stress and tolerable stress that also happen to us. And so there is this continuum, but when we're looking at the impact of trauma and that impact of those early experiences on outcomes, we're looking at sort of this toxic stress part of the continuum. And the reason that's important is because when our stress response is activated, or when we have these high levels of cortisol, this is true even for adults, but certainly for children, the prefrontal cortex of our brain, the learning, thinking, rational part of our brain, literally goes offline. And the limbic system, or the core processing in our brain, is what takes over. So that fight, flight, or freeze, that space is where you live when the prefrontal cortex goes offline. So I like to help folks kind of think about it as a switchboard, right? So that prefrontal cortex and the limbic system, the amygdala sort of serves as a switchboard. So when information comes in to our limbic system, the amygdala decides if this is dangerous or safe, right? So like if the lights turn off in the room that I'm in right now, the amygdala will help me decide, is that safe or dangerous? But when the prefrontal cortex goes offline, or if people are chronically stressed, the amygdala actually has a hard time figuring out real danger from false danger. And so the idea that everything is dangerous is sort of what happens. The reason that's really devastating is because, as we know, the memory of our experience gets stored in our bodies. So it doesn't just stay in our brain, doesn't just affect the way our brains grow and develop, but because the brain is a central processing for our body, it affects all the systems in our body, from our immunity to our blood, to our hormones, to our muscles. And that's where the effects of the load comes into play. So I want to spend the last few minutes just kind of making sure that we can take that information that we know about ACEs and about the impact of trauma, now that we sort of can ground ourselves in that research and in that data, and instead begin to look at, now what do we do about that? Because I can tell you that 99% of the time when I share this information with folks, the next question is, now what? What do I do about that? And I know that's what you're trying to tackle in this learning collaborative. I think the important thing to acknowledge here is that ACEs are not destiny. And I think we're kind of on the same page about that, especially those of you who heard the speaker from this summer. Anyone who's experienced adversity in their life can be resilient and bounce back. And when we work together in community, we can ensure that they will. So there are a couple of resources that I'd like to kind of direct you to. One of them is through the Center on the Developing Child. They've developed a set of principles that they feel help buffer ACEs. And there are 3 of them, which you see here. They're the 3 buckets that they think communities should invest in, or programs should invest in, is first and foremost, reducing sources of stress for people. So thinking about the environments that you create for families and in your community, just what can we do to reduce those sources of stress? How can we help folks invest in self-care and make sure that we're not adding to stress? Secondly is strengthening core life skills. And I think a lot of the work done in home visiting focuses on that. How can we help folks begin to understand where they've come from and how they can move forward and really build on those core life skills like executive functioning and decision making? And then lastly, supporting responsive relationships, which I think many of you have and do in your work. And so the power of having someone who can be supportive and responsive to buffer the effects of ACEs. So there is a video here, which I will, it's linked in the slide deck. I'm not going to share it right now, but it kind of talks about the ways in which these things, when they are in place in programs and in communities, can have outcomes for families. So it's just about 4 or 5 minutes. I kind of want to end with some data. I feel like in many ways that I'm preaching to the choir. As I said, you all are my people, but I want to help us understand the power of resilience. And this is where I hope that through the Learning Collaborative, you can really kind of harness and begin to figure out how to share this or leverage this in your work. There is some data that's coming out of Washington State. We actually asked some of these questions in 2019, so I hope we will have some Michigan data as well. But Washington State has actually identified what they call 4 resilience factors that make a difference in not ACE prevalence, but in the negative outcomes of ACEs. And I'm going to just quickly walk you through these. There are 4 things, and to me, this is where the rubber hits the road. this is where I think every single one of us has an opportunity to make a difference, and where I think home visiting programs are especially positioned to do these things in our work. So the 4 things that Washington State is looking at as resilience factors, the first one is literally and simply just feeling social, emotional support and hope. So helping individuals feel like they have support and hope for the future. To me, that's huge. And that's much of the message that you all heard this last summer, that regardless of where we came from, there is hope for the future. So helping folks do that. The second one is having 2 or more people you can count on. So giving that concrete help when you need it. So connecting folks to resources, helping them get their needs met. And not just one person, but 2 or more people who can help them. The third one is known as community reciprocity or social connectedness. And this is living in a place or space where you feel like you're part of something, where you watch out for one another, you intervene when there is something that needs to be handled, you do favors for one another. I often tell folks this doesn't have to be sort of a zip code or a city, but instead could be a faith-based community. It could be a playgroup community or a mom's group or a school group. But just being a part of something and feeling connected is the third resilience factor. And then the last one, which I think is really powerful for folks like home visitors, is the idea that individuals can reach outside their social circle to get the help they need. That's known as social bridging. So when I think about the work I did in home visiting, the power of an individual to feel like they can actually reach outside to someone that they don't know, whether that's in community or maybe an expert or a professional, and have the ability to reach out and get that help is really powerful as well. And I think that's a lot of the work that we do in home visiting. So I'm just going to briefly, I know we're at time, I'm just going to briefly share with you this data because I think it's extremely powerful. When I talk to folks about this, I think sometimes, depending on where you sit, people get it, but it's hard to figure out, like, so what are these, how do these things really connect to the outcomes that happen with ACEs? So I'm going to orient you to this slide and then kind of walk you through just a couple of them. So this is from Washington State, and this is looking at ACE scores. So you can see here that in Washington State, they kind of pulled them into 3 buckets. So those with 0 ACEs, those with 1 to 3 ACEs, and those with 4 or more ACEs. In Washington State, they looked at ACE scores as it relates to smoking. So those folks with 0 ACE scores, 20% of them also reported that they were smoking. About 28% of them who had 1 to 3 ACEs reported smoking, and those with 4 or more ACEs were the highest of those that reported smoking, so over 35%. So just like we learned before, the higher a person's ACE score, the higher the likelihood of this negative health outcome or this risky behavior, in this case, smoking. The important thing to note here, though, is the light blue bar. What they found is that those with low support had higher rates of smoking than those with high support and hope. So remember, the first resilience factor is just feeling hopeful about the future. When a person said, yes, I have 0 ACEs, and yes, I smoke, but I also have this feeling of high support and hope, the percent of those smoking went down. So fewer people who felt supported and hopeful reported as smokers. And you can see that that was quite dramatic across the ACEs. What this says to me is that when this specific resilience factor is in place, the negative outcomes, not the ACE score, but the negative outcomes are buffered. They're less when we can provide people with support and hope. We also then looked at mental health. So people who report having more than half of last month poor mental health days. And you can see when there is this sense of support and hope, it was dramatically less. So even if you have 0 ACEs, there were some folks who said, yeah, last month I had a lot of poor mental health days. When they had low support and hope, there were higher incidents of these poor mental health days than when there's high support and hope. And while that makes sense intuitively, when you see the data, it's really powerful. And then they also looked at physical health. So again, when there's support and hope, the physical health, the poor physical health is less by ACE when we have this high support and hope. The second set of data is just looking at concrete help. So they literally asked if you have 2 or more people, that would be more help. And if you had under 2, 0 or 1 person you can count on, then that would be low help. And they looked at things like having enough money to feed your family. And of course it makes sense. If I have 2 or more people I can count on, then I'm less likely to report that I have not enough money. And so the literal difference of having more help. The same is true with when looking at depression and when looking at overall health. So the message here is that there is some science behind resilience. And it's important to understand that while we can't change a person's ACE score, we can actually affect their health and development. So we can move, like think of it as a scale, we can move that fulcrum or that triangle so that over time, when they have more resilience factors or positive life experiences, the negative outcomes are less. There's also a video linked to this slide, which I would encourage you to look at. Again, it comes from the Center on the Developing Child. It's only a few minutes long, and it does a really nice job of explaining the science. I just want to close with making sure that while half of the presentation today was focused on ACEs, the goal of that was to provide us with some common meaning and shared understanding. And to me, the message of hope is around resilience. It is not a superpower. It is something that anyone can learn and develop. And it can happen. It's never too late. It can be built over time. It can be built with practice and positive experiences. And it's like a muscle. When we understand about it and when we do it more, then we're going to be better at it and we're going to continue doing it more. And again, this is where I feel like this learning collaborative and the opportunity to actually try some new things come into play. The last thing I'll say is I think it's really important to remember again that this is a journey, and there are 13 teams, I think, that are working in this learning collaborative. So you're all at different places in this journey. And some of you may be further ahead than others. That's fine. And just like that for programs and for communities, that's true for individuals, that you may be at the beginning of this journey or you may be a little bit further along, but just understand that it isn't something that happens overnight and that it is something that through time and experience and agency buy-in can move along. Here are the references that I shared, and then what I had in the original, so that I put it in the chat box, but there is, I'm just gonna really quickly show what it looks like. So this is the Google Drive, and so these are all the things that I shared with you. So the slide deck, I have a couple handouts in here. Here's the data that I shared. So I just wanted to make sure that folks were aware that all of that information is there, as well as follow-up. So I'm going to stop sharing my screen. Is that okay if I stop sharing my
Google
screen?
Drive.
I'm sorry, go ahead.
Oh, it's Brenda. I was just saying if you were showing the location of the Google Drive and the docs in it, we were not able to see that.
So I just tried to pull up my Internet Explorer. So, but if you click on the bit.ly, which is in the chat box, that should take you to the Google Drive folder. And in there are about 10 documents, including the slide deck.
Thank you, Jody.
Well,
I think this is a really good place to start.
And my contact information
Are there any?
Yeah, my contact information is at the end of the presentation as well. And so I'm going to continue, my colleague Mary Mueller and I are going to continue working with Brenda and are available to answer any questions or be helpful as you move through this process.
Thank you so much. Are there any ending questions for Jody?
So it looks like you all have a group site location. And so because I wanted you all to have this for your work coming, you know, in the next hour. And I was still working on the presentation. I wasn't able to get all of this to Brenda ahead of time, so that's why I put it in the Google Drive, but I would hope that you'd be able to put it in your, wherever you're keeping all of your information, so that it's all there. But I wanted to make sure it was available for you so that you had it during your work time this morning.
Thank you, Jody.
Awesome. Well, thank you so much, and good luck as you take on the Learning Collaborative, and I look forward to connecting with all of you as we move forward.
Thank you again. So after having heard Jody's presentation and tying together those pieces of ACEs, and ACEs not being a determination of where you go, really having that resiliency piece being a focus here, we're going to move into the introduction of the ACEs Resiliency Change Package, which you will be working on for the Learning Collaborative for the remainder of this fiscal year. And again, it is very developmental this year, so we are open to any and all learnings as we move through this. So just to pop back to the Learning Collaborative Engine, Robin Vandermoor had held a webinar last week to kind of kick off the understanding of what the Learning Collaborative structure is. And I just wanted to pop back into a couple of her slides to share that where we are at in the Learning Collaborative Engine of having these 13 teams working together over the course of the rest of this year is we are at Learning Session 1. So in this session today, you'll receive the documentation materials that you'll be using and begin to start thinking really as a team. I know that many of you have had discussions already about where your interests lie, but thinking as a team, how will you formulate that first PDSA cycle and start the work here? So the change package again, the link to the recording of the webinar that Robin did is in the lower right-hand corner. It is on group site in the file cabinet. So if you want to go back and ground yourself in exactly what a Learning Collaborative is and what the expectations are specifically, that's a good thing to watch. We have documents that we've developed. You provided feedback on the key driver diagram in December that really focuses in on revisions that we feel align with where the research is at and where you all are at. We have a SMART aim statement that relates to our overall Learning Collab measurement this year that I will get to in a moment. We have a measurement strategy. So in the past with Learning Collaboratives, we've had monthly data collection of outcomes and process measures at your specific programs that we collect and then aggregate. This year is going to be a little bit different because of the type and where we're at in the journey of this Learning Collaborative development. And then you have your team charter, which by this point, many of you are familiar with. For the Learning Collaborative, it is specific to the ACEs Learning Collaborative. So going back to grounding us in where we came from in choosing to have this Learning Collaborative based upon ACEs Resiliency. We've had feedback from LIAs over the years, and especially in follow-up to Jody had referenced in the summer, the home visiting conference, and having those presenters come in on ACEs and resiliency and the importance of resiliency and impacting long-term outcomes really fired up lots of the home visiting programs. And so the state felt like, okay, this is an area that everyone is showing a lot of interest in, and then there was some voting around whether this should be one of the Learning Collaboratives this year, to which lots of home visiting programs said yes. So this was one of the two that was chosen based upon that feedback. When we went into developing kind of the change materials and looking at where the research is at, some of the important pieces that we pulled in were, one, this screenshot that you see here, and it's one of the documents that's in the group site folder, and you may have seen a few years ago if you were a MHVI home visiting program, which is an issue brief that came out from HV Impact, specifically about creating trauma-informed home visiting programs and ACEs, and talking really about that journey that Jody was referencing earlier in the pieces that need to be in place in order to have a strong trauma-informed program, knowing that ACEs has long-term impacts, and we know that the levels of trauma with home visiting programs are likely higher because you are focusing on the folks who have higher needs just in your eligibility decisions. So you're targeting those with needs. You know from your experience, as Jody said, there's intergenerational transfer and adversity as well. And the noting here in the HV impact brief was really that trauma-informed care strategies not only have positive impacts for the families you serve, but also in preventing burnout and turnover among your staff, because it is a changing a way in which you are approaching this. We also took in quite a bit of our learnings from the Early Childhood Comprehensive Systems pilot that happened a few years ago with some home visiting programs here in Michigan. And there were two elements to that. One was piloting some ACEs training and some screeners for related challenges that come out of ACEs scores with the home visiting program, and also some community level quality improvement work to build trauma-informed systems at the community level. And out of that work, we had a great deal of learnings and feedback from those home visitors and those supervisors and those community partners about how this went and what was really frustrating, what really needed to be in place in order to make this successful for both the staff and the families. Part of that ECCS grant was the creation of the MDHHS Trauma and Toxic Stress piece, which Mary Mueller has headed up for a while. And the state has, over the last couple of years, really built up the support for programs in Michigan around resources and how to work with families who are experiencing ACEs and focusing on that resiliency. So definitely when we started embarking on this, my first thought was we need to connect in with Mary Mueller. And then she also said Jody Spicer is there as an ACEs consultant. And it's like, who is better to partner with and be a resource for you than someone who has also had that perspective of being a home visiting supervisor and doing home visits with families. So we took a lot of information into development of this package that we are rolling out. So our key driver diagram. We have 4 main drivers, and they line up quite a bit to that Missouri journey model that Jody showed earlier, in which phase 1 is being aware, phase 2 and 3, you're becoming sensitive and responsive to trauma, and then at stage 4, you're getting into providing trauma-informed care and doing that implementation. And knowing that we have 13 teams who are in very different spots along this journey, we knew that we'd probably have lots of teams that will end up in the first 3 drivers, where you're building that support basis that you really need to have in place before launching into using ACEs score history and resiliency tools in home visits with families in a meaningful, ongoing way. We refined the key driver diagram, and I'm going to switch to sharing it in just a moment, but we have a draft aim statement on the team charter that is dependent upon a survey that is going to be launched next week, which Nick will talk about in a little bit. But our draft aim statement that we have right now is by September 1st, 2020, the MHVI ACEs Resiliency QI Learning Collaborative will increase the percentage of home visiting staff reporting comfort in supporting the resilience building of families who have experienced ACEs. And we do not yet have a baseline for that, but our vision is to create an index of some of the questions on the survey, depending on the feedback that comes back, that will be used for the aim statement. So we are very much in our own plan stage here and getting our baseline information. So I am going to switch to walking through the team chart or the key driver diagram as it stands now. So with the key driver diagram, again, your aim statement is all the way over to the left. But for those who are new to the key driver diagram, that is our overarching goal, the bigger thing that the whole collaborative is moving towards and working on over the next several months together. Then we have primary drivers under there, which are really those check-ins on that journey model. That you have the training in place, the infrastructure in place, the support for practice, and then a fourth driver is that piece around implementation. There we go. It's down there at the bottom. Actually, get some things out of my way so that I can see the whole thing. And then we have secondary drivers under those. And really this driver diagram feeds from the right to the left. So we have these specific ideas to test, which will be the individual ideas that your team will select one or come up with an innovative one maybe. And those things that you are trying will feed into the secondary and primary drivers. So when we are looking at the creation of this, those of you who participated in the initial feedback session gave some great feedback around what we had as the initial primary driver one, packed a lot into it and was kind of overwhelming to look at in that way. So we broke it out into those pieces of training, infrastructure, and support for practice. So under PD1 and training, we have home visiting workforce has a foundational knowledge of trauma and resiliency. And the secondary drivers are around the program promoting trauma-informed services through ongoing training and professional development of staff. And then home visiting staff are familiar and comfortable with ACEs and resiliency concepts and know how to apply to their everyday work. And the ideas to test here are around, the first one is about collecting with your local trauma-informed services and ACEs coalitions to access initial and ongoing training and professional development. One of the pieces of the feedback that came in that session we held a month ago was around making sure that there's also a connection to the community level resources and collaborations that you have, if those are present in your community. There are several communities around the state where it is the case that there is already strong work going on in this area, and absolutely tapping into the people who are already working in this area for assistance and connection to the work and support is an important piece. The second one here is integrating evidence-based trauma-informed care principles into home visiting programs' standardized processes. And then we have a resource there that talks about how this might work. Program facilitates ongoing access to training, professional development for supervisors and home visitors on the impact of ACEs, intergenerational transfer, and the importance of trauma-informed practice. And we reference you back here to a couple of resources. Here, one is that MDHHS trauma and toxic stress piece. Also the near at home, a few of you are already familiar with that piece in depth. And one thing to note here is when we are giving you resources, that doesn't mean that those are the only resources in that area. In our research, we found lots of things that are out there. So if your program or your community level collaborative has identified other resources in these areas that fit your community and your program better, absolutely don't feel like you are tied to the specific resources that we're pointing to here. These are just the state level known and nationally level known supports that we saw in our research. Home visiting staff are trained in resiliency identification tools to be used when supporting families in building on existing strengths. Home visiting staff are trained on the use of protective factors. And I just noticed a typo in there. It's always a work in progress here. And then training supervisors and home visitors on secondary trauma prevention. And that was a big piece of feedback from home visiting programs in the past, is this piece around secondary trauma of the staff themselves. Are there any questions on this driver and the ideas that are within it? Okay, well, I will move on to the second one, which is infrastructure. Home visiting program has infrastructure and community collaboration supportive to trauma-informed practice. And under this, the secondary drivers are program policies and protocols that are aligned to support resilience at individual, program, and community level. And the second one is program has established protocol, including policies and procedures supportive to ACE's resiliency building, including ACE history identification, resiliency factor assessment, follow-up, and planning. And this one again starts with that collaboration with your local resources. If you have one in your community, tap into them. The second one is utilizing standard program process for gathering ACE's history and utilizing data for surveillance of the program-wide needs. And this is more at an aggregate level of not identifying resilience and ACE's history with a particular client and setting goals around that, but looking across your program. Do your incoming or existing clients all have some shared areas of ACE's history or things that you could target a little bit as a program? So knowing that you have a lot of families who are coming in where the primary caregiver has some history, an ACE history of sexual abuse. Do you need to really beef up those resources and supports that you might have for someone who has experienced that in the past? That is what we're talking about here under that bullet in terms of surveillance for program-wide needs. The third one is establishing program policy and protocol for explaining ACE's history and gathering process to the families. So what is it? Why is it important? The importance of building on strengths, and that piece about confidentiality. So coming out of some home visiting program feedback in the pilot and in the research is, and I believe it's in the Near at Home manual as well, this piece around confidentiality. So if you are discussing ACE's history with families, it can be touching on some things that are very confidential, and how will you handle what is disclosed. Standardized program policies and process for follow-up support, post ACE's history and or resiliency tool in home visits with families. So making sure that you are all on the same page on how you will address this. And that would hopefully help with that now what sort of feeling that happens when you do an ACE's history or resiliency tool. Establish program policy and protocols for home visitors' response to ACE history score, perhaps having a decision tree. Identify or create program data sources that support decision making. So tracking systems for ACE's history, resiliency scores, home visitor provided supports, referral follow through. Are there questions on the second driver? Okay, moving on to the third one was the support for practice. So kind of internal supports you have working in your favor. Home visiting program provides ongoing responsive supervisory support to increase home visitors' ability to support ACE's resiliency. We know from the research and from feedback from those practicing these particular tools that it is very important to have that internal piece of support for home visitors. The secondary driver number one is program leadership promotes a culture of self-care and secondary trauma prevention. The second secondary driver is supervisors provide supportive environment for trauma experienced by home visitors, be it secondary or their own personal trauma. The change ideas here are regularly screening supervisors and home visitors to identify secondary trauma using a tool such as the ProQual, which some of the NFP programs have used in the past. It is a tool for supervisors to use to assess where burnout and secondary trauma may lie. Establish and utilize linkages to mental health programs or specialists for supervisors needing guidance on how to support staff, as well as for home visitors who might need support beyond that available in supervision. So what happens, who would you link to if the need is greater than what can be provided in the program for supporting staff? Utilize regular reflective supervision to develop strategies with the home visitor for overcoming barriers related to ACEs history, identification, or building resiliency with caregivers. And then utilizing reflective supervision and motivational interviewing strategies to support home visitor self-care, secondary trauma, and or personal ACEs. Are there any questions on the third driver? Then the final one here is that piece around implementation. So that ends part of the journey where you've got the base things in place and you have moved to implementation. And this one here, the primary driver, is caregivers who experience ACEs are supported to build on strengths, which I know is an integral part of home visiting programs overall, but this is, again, as Jody talked about, it's being very concerted and conscientious and planful in how you will approach this. The first secondary driver here is program integrate strategies to increase caregiver resiliency through knowledge of healthy relational interactions. The second one is caregivers are aware of the benefits of ACEs identification and resiliency building. And the third is caregiver goals based in resiliency are created early and revisited regularly. And the change ideas here are establishing short and long-term goals based on the caregivers and family strengths identified through the ACEs history and resiliency tool, introduce the near at home framework, early in visit schedule to gain engagement and establish safe environment with families. We know that the near at home is one of the most popular tools with home visiting programs and is being used here in Michigan. So if you are using the near at home framework, this would be a change idea for you. Make tools and resources readily available to home visitors for use with caregivers, such as the Strengthening Families modules and the near at home, providing resiliency building tools to caregivers, such as the 1-2-3 care toolkit from Spokane, equip families with materials to support children's development. Again, we reference that toolkit from Spokane, and one of the reasons that we do is that it has pieces in there that break it out by age of the child. So it's kind of a good one because it focuses on their different developmental levels. And then employ parent-child interaction tools to identify and plan goals to support healthy relational interactions. And some of the tools listed here are ones used by models in Michigan already, the dance for NFPs, cheers for HFA, and the piccolo for some of the other programs. Those are some of those tools that are very strength-based in looking at what are those resiliency pieces maybe that are already in place that can be built upon. Are there any questions about primary driver 4? Stop it. I'm going to go back to the presentation to move through the pieces of the change package. So we have talked about the key driver diagram. And that key driver diagram is quite large, and we like to give you tools each time we come together and launch one of these things for how can a program think about narrowing in on what is it that your team would like to work on, what is it that the team is passionate about, what is it that the team is ready to launch into, and prioritizing which driver you want to work in before then narrowing down to the different pieces within that driver that you could consider. And I'm actually going to drive Haley nuts because now I'd like to share this document itself. I shouldn't have come back for just one slide. So I'm going to share this document itself. And this document is up on group site already in the change package folder for the ACEs Resiliency Collaborative. And this worksheet, I have some step-by-step instructions in the slides going forward, but this worksheet is meant to help your team walk through the drivers, consider where you're at right now individually and then as a team so that you can compare where there might be differences. So you're going to be rating those drivers based upon the current status of where things are and the potential impact that working in that driver could have for your program. And then prioritizing this. So in the past last year, if you were in a learning collaborative, we used a matrix, a prioritization matrix for prioritizing change ideas. But you can also do this at the driver level to help your team agree upon and come to consensus on which driver you want to work in. And then the last part of this worksheet is once you've identified as a team which driver it is you want to work in, going through each of the secondary drivers and talking about where you stand on those, and then working through those individual change ideas. So you are working from left to right on that key driver diagram to first identify which driver might we work in, and then to think about the secondary drivers and where you stand with those, which could lead you to eliminating some of the change ideas from consideration because they're already in place, or highlighting where there are differences in the understanding of those particular change ideas within the program, which could lead you to naturally gravitate towards one change idea. Stop that. Poor Haley will get the, okay. Kim Harris has asked if this is a document that is required to be submitted. It is not. It is meant to be a helpful worksheet. We have also in the past provided you with a worksheet that was a stoplight assessment for drivers, which is also another helpful tool to have in your bucket as you're discussing things. It is not something that's required to be submitted. This is totally something for the team to do to help kind of facilitate through that conversation of where is the understanding of the individual members of the team, where can you come to consensus on a spot to work? Good question. Are there any other questions on that prioritization worksheet? Okay, so when you are working through this, if you are using this as a tool, the first thing to do is separately complete that Part 1 assessment of primary drivers. Noting that current status and potential impact score, it gives you that chart for rating them in a number scale. Add any notes in the space provided, and then talk about those as a team. That can help you in identifying differences of opinion there. Separately plot those scores in the grid on the template handout before you do that so that you can visually see where your team is perhaps not on the same page. Or you might see everybody wants to work in driver 2. It is in that upper right-hand corner, and you have passion and will within the team to work in that one. In that case, serendipity is on your side, and you can just move forward to thinking about, okay, now that we know the general area that we're working in, let's look a bit closer at the secondary drivers and the change ideas. Part 2 is that piece around the specific driver and talking deeply about your drivers. Part 3 is that assessment of secondary drivers. And again, I would ask that you separately rate them and then come together and talk again, because this is always this separate rating and separate brainstorming before coming together is always a great piece to do, because it highlights where, sure, something might be in place, but not everyone is aware of it. Or there may be a perception that everyone has all the training that they feel like they need and we're good to go. But when you get the opinions of others on the team, it may not reflect that. And it might be a time to take a pause and work a little bit on beefing up that training piece. when it gets to the change idea selection, so you've got your driver chosen, you've talked about your secondary drivers and where you're at. Again, it's that independent piece first, having the team members look at those change ideas that are in the driver that you're working on and independently go through it and cross out those that they feel are already strongly and consistently in place. And then as a team, again, review. Did you all agree on the areas that are already in place? If not, that might point to a fast kind of area to work in that could give you some change and get you to the place that would be best for the whole team, making sure everyone's on the same page. With the ones that are not crossed out, rate the remaining test ideas in order of which changes are your top 3 or 4. And as a team, discuss again, is there a change idea that's a priority of all the members? If it's a priority of all the members, then that change idea is going to have your whole team behind it. You're going to have the goodwill and the passion of the members of your team behind that idea. And again, I mentioned this as something that we did last year, but number 4 is if you have trouble deciding as a team on which change idea to do, consider using a prioritization matrix just to rate those ideas and finding those that fall into that upper right quadrant of low effort, high impact. That can help you come to consensus as a team if you're having troubles deciding exactly which one you want to do first. And then my last thing here would be the notation that this is a very developmental collaborative. So if you have a change idea that is outside of what is listed on the driver diagram already, but you feel falls within these, reach out and we can create an innovation idea here that we can use for learning going forward. We, again, devise this based upon feedback and experiences and research that is out there. But you are the programs that are out there implementing this work. So if you have a change idea that's not up there, you can absolutely consider it as an innovation idea. We'll just want to talk through where does it fit within the drivers and then move forward. So I'm going to hand this over to Nick after just a moment of pausing to say all of those pieces that I just ran through are going to be things that you do outside of this session. So we're stopping at a certain point and then you will move to your individual work time, or perhaps you have team meetings coming up where you're going to tackle this. You can reference back to these slides if you're using those tools as a team and use those as guidance as you go through. But now I'm going to hand it over to Nick for a couple of slides to talk about our measurement strategy, because we are not using the monthly data collection, we are using a survey.
Thanks, Brenda. As we talked about last week in the LC overview, this measurement strategy is tailored to document performance and progress towards your goals and opportunities for improvement. So what we did is we developed a survey in REDCap, and most of you have sent your contact lists to me. If you haven't yet, you can please send that my way, and I'll be able to get everybody situated and ready to go. But what you'll see is you'll see the survey link come through your email, and there will be a personalized link that's just for you. So if you forward it to somebody, it won't work for them, but you'll click on that link, it'll take you to the survey, and you'll want to complete that survey within 2 weeks of receiving it. We'll send you a total of 3 reminders if you haven't completed it, and we are fielding that survey at 3 different time points. Which will be, the first survey will start next week on Tuesday, and it'll run for 2 weeks to February 4th. Then we'll have another at April 27th through May 11th, so another 2 weeks. And then the final August 24th through September 4th. because this LC is very developmental and hasn't been used over repeated cycles, you'll notice this measurement strategy is a little bit different in that we're not doing that monthly data collection, instead using these surveys over 3 different time points. And we'll aggregate the data and compile it for reports back to your teams and include those in your monthly updates. Oops. Oh, yeah, that's not yours, not mine. So the aim statement, again, as you saw in the key driver diagram, was by September 1st of 2020, the MHVI ACES Resiliency QI Learning Collaborative will increase the percentage of home visiting staff reporting comfort in supporting the resilience of building of families who have experienced ACEs from X% to Y%. And in keeping with the aim statement, most of our survey, I'll say upfront, is going to be based on that comfort piece. How comfortable are you with this or with that? So for each primary driver, which we just went over in the key driver diagram, there will be a different set of questions that are looking at different types of items. So the first driver there is going to be survey questions that are going to gauge your training experiences and measure your comfort levels with applying different concepts of ACEs and resiliency in your daily practices. So like I said, what is your current comfort level with X, Y, or Z? We'll also ask you in that primary driver section of the survey about maybe some of the training experiences that you've had, or if you've had any, and maybe a little bit more information about those. For the second primary driver on infrastructure, the questions are going to look at your own awareness of internal and external program policies and protocols and how clear and comprehensive those are. So we'll ask you a little bit about some of the policies and protocols that you have within your organization, and if you know of any external programs that are doing similar types of work in your community. So one of those types of questions will be, to what extent are X, Y, or Z clear and comprehensive? The third primary driver, that support for practice piece, will measure your feelings of support and comfort in your programmatic support systems that are related to ACEs and resiliency practices. So we'll ask you, in your role as a home visitor, a supervisor, or an administrator, how comfortable do you feel with X, Y, or Z? And then for that last primary driver, the implementation piece, we're going to be measuring your comfort and preparedness related to implementing ACEs and resiliency results with your families. So what is your current comfort level with X, Y, or Z, or how prepared do you feel to do X, Y, or Z, or to use these results in these different ways? And so with those, we hope that those are comprehensive enough to get back at our aim statement of increasing that comfort in supporting the resilience building of families who have experienced ACEs. If there's any questions on measurement strategy, we can field those now.
Just a note, we moved to the 3 points in time, baseline, midpoint, and final survey in lieu of monthly data collection, because we knew that this is very developmental and teams were in very different spaces, so it wasn't really appropriate, and we knew there would not really be available from teams a lot of outcome and process measures that we would really generally collect in a learning collaborative on a monthly basis. So this is looking toward a data collection that gets at the heart of the collaborative. And then if we run this repeated cycles at a certain point in time, hopefully teams will be at a point in our practice that we will be able to move to that type of learning collaborative structure. Another note about the survey is that it is going to home visitors, supervisors, and administrators, because we know with some of our programs, we have staff who serve in multiple roles, and that each of those roles plays a key part in this underpinning and this being able as a program to be in a place where you are comfortable and able to provide trauma-informed care and take care of your staff. So when you see the survey, it will ask you which roles you fulfill, and different questions will unfurl based upon which roles you select. But we know we definitely have some programs where one staff member might be both a supervisor and carry a home visiting caseload, or an administrator may also be a supervisor as well. Rich has asked a question. Just to clarify, we won't have monthly reports due the 15th of the month. Rather, we will have 3 surveys due at 3 points in time. This is correct for the measurement strategy. So you will not be submitting data monthly. You will still be sending or uploading team charter updates monthly, and the aggregate updates on where all the teams are at, so that you can have some information on a monthly basis about other teams who are working in areas that you might be interested in, or working in the same area and you want to connect with them. Those monthly update reports will still come out. They will have the team charter updates that you're submitting each month, and will carry forward the data that we get back from the survey. So for the first few months, it will carry forward that baseline data, and that won't change month to month until we have the next iteration of the survey, at which point you will have the midpoint comparison to the baseline. So there will not be monthly measurement strategy pieces, just the monthly team charter updates. Are there other questions about the measurement strategy? Okay. Oh, now they're rolling in. Okay. Yes, Carrie, it is still 2 full PDSA cycles before September, and that is something to consider when you're looking at your change ideas, and if you want to modify or make an innovation. With QI, we are always encouraging you to think as a team about trying strategies that are in that upper right quadrant of the prioritization, that are high impact, low effort. Go for those first. And if you have questions about how maybe to tailor down your cycle so that you're taking small chips away from a bigger concept that you want to work on, I am absolutely free to do consultation, as all of the QI coaches are. It's always an open door to call and just walk through. This is what we're thinking about. We're not certain that we can do this within this period of time. What would you suggest? And we can talk through those pieces. Okay, so let's move forward. I know we're getting close on our time. Okay, so the team charter planning tool, this is your individual team roadmap, and it is also the Learning Collaborative monthly update tool. So this is the piece that you will continue to submit on a monthly basis, and we will send out monthly compiled reports across all the teams of the collaborative for you to use in your work. So the team charter looks similar to team charters of the past. And it is right now available in group sites. It is, let me just, you know what, let's take a moment to go to group sites so that I can show you where it is and bring up the tool. And this is your program level PDSA planning tool. So it has at the top some, my share screen up here. It has at the top a couple of things about the collaborative as a whole. So it has the collaborative aim statement, and it has the collaborative problem statement. Here. So within group size, this file keeps popping up menus, the file cabinet. And where our ACES materials are under Current QI Learning Collaborative, FY20 ACES Resiliency, and Change Package is where these documents are. So with the team charter, when you want to download it, you click on it and it just pops it down for you. And then you can open it and save it down to your own computer drive. You won't be able to save it back up here and make modifications to this document. It is a template, and with any document within GroupSite, you can't make changes to it where it's housed in GroupSite. You have to download, work in your document, and then upload your fresh version. So the FY20 QI Learning Collaborative for ACES Resiliency, again, has those collaborative-wide pieces at the top. The collaborative-wide aim statement will be modified based,
You have to share.
Oh, I have to share.
Now.
Okay, one moment. Oh, there it is. Okay. So when you download the tool, it is very much probably going to be familiar to those of you who have been in Learning Collaborative in the past. It has that collaborative problem statement at the top that we are all working around. And then the collaborative aim statement, which right now has placeholders for the baseline and the goal. That will be based upon the initial survey results that we get back. So again, we are in our plan stage at the whole Learning Collaborative level in gathering our baseline data. You will choose your team name from the drop down, and it was working this morning, so maybe it's not working right now because I haven't saved. Oh, enable editing. You're watching me learn in real time. Okay.
Okay, now you have to.
Now I have to reshare. Okay. All right. Now will it work? Yes, it will. So you will choose your team from the drop-down. You'll note the PDSA cycle that you are working in. It has 3 options here because you are always welcome to do more than 2 PDSA cycles, but MDE and MDHHS have both asked for at least 2 cycles, so a 2-cycle minimum. And then the cycle topic is in open text, so you will type in your overall area that you're working on. Team meeting dates, the team roster, who's on the team, and then there's a spot for monthly updates. And this is the piece that's important to that monthly submission of the team charter and the updates as you move along. So your first submission will be coming up in February. You will not complete anything in the monthly update table for that because your first submission is just that you've started on that plan stage. It's that baseline of the information of the driver you're working in, secondary driver, the idea you want to test, some information about your process area. Those base pieces of the plan stage is what your first submission will be. And then going forward, starting with March, you will be submitting your updates reflective of what you did in February. So you'll start using this section of the team charter at that point. When you get to March and you're reporting on what happened in February, and just include a little information on what you did that month, what you learned if you were reviewing your process and you learned something really key as a team. It's good to note that here. And then did you update your team charter? So if you, as you go along, revise your aim statement or go back and revise different pieces, add people to the team, take them off, those sorts of things, just check the box for yes, you made a revision, and that will trigger the team to know, okay, this team has potentially made a change to their aim statement or their improvement theory, and we need to update that for the greater updates going out to all of the teams. As always, as you move through your plan stage, you can modify your aim statement as you learn more and discuss more as a team about where you are and decide what you want to work on in identifying a measure. You'll just want to make sure that you have your aim statement locked in before you go into your do stage, because it is the overarching goal of your PDSA cycle. You'll be putting in your improvement theory. If you do what change idea you're working on, then what do you expect will happen? Your plan for your test, who is doing it. Something to note here is you do not have to test across the entire program if you have a large program. Always consider that you can pilot test with 1 or 2 workers or in a particular area. You don't necessarily have to do a test across the whole program. We encourage making this feasible for teams and testing things out on a small basis before you roll it out on a bigger basis is a very key piece of QI work. And that's another thing that we often consult with teams on, is how to feasibly do a test. And one of the recommendations is often, just test with a couple of staff or with one partner or in a particular area or zip code. It depends upon what you're working on, but you can tailor down tests just to try something out. Your start and end date, your plan for your data collection. You won't have monthly data measures. You could consider using the points of the survey if there are things on the survey that you want to look at, but most likely you will be using some process measures or outcome measures at your local level. So your aim statement will be around whatever measure it is that you identified that is closely tied to the idea that you're testing. And this will be very different depending upon what you're testing across teams. Your plan for your do stage, what you're doing at particular dates. And then when you get to the end of the cycle, your study and act should feel pretty familiar. Are there any questions about the team charter? Share. Okay. And I know that we are really on our time here, but again, you're sharing your PDSA planning tool, which is the team charter, each month by the 15th of the month. The first submission, because the 15th fell on a weekend, is the 14th. And this year we're uploading, or you will be uploading your PDSA planning tools to GroupSite, which is a new feature this year. But it allows a couple of things. One, we get to know kind of in real time, and it's not filtered through a QI inbox and then to the staff person who would be doing your review. And also you can look at what other teams are working on, which is another way to use this collaboration of other teams. So you can check in on what they're doing as well. So the submission of the team charter, your team will upload a copy of this tool to GroupSite. A guide for how to upload was sent to you via email, but it is also available on GroupSite in that folder that I showed you a little bit ago, and there is a link to it right here as well. Updates should be saved by the LAA team to the FY20 ACES Learning Collaborative folder for the month of submission prior to the 15th of each month. Note, this is something that gets me about GroupSite, but the folders are alphabetical. So it's a little weird because it doesn't go in the calendar, and it rattles my cognitive dissonance. But just know that they are not in the order of the calendar, they are alphabetical. So find the month for which you need to submit and upload your team charter there. I will receive a notification of file uploads, as will the other advisors, and we'll provide our feedback via email. So you will not be receiving your feedback on group site. The individually tailored feedback will be coming to your inbox. If you need support uploading your PDSA planning tool to group site, you can reach out to Haley. She is magical at walking people through this. So if you get to that point and you're having some challenges, reach out to her and she can help you with that. So next steps, Nick talked a little bit earlier about contact lists. If you have not yet sent the contact list for your home visitors, supervisors, and administrators to Nick, please do so as soon as possible. As he noted, we are going to start fielding this survey next week. Use your team work time today to begin your key driver assessment and team discussions to narrow down on the primary driver you would like to work in and the secondary driver and the change idea. Begin filling in your ACES Resiliency Planning Tool, your team charter, and upload an initial draft to group site by February 14th. And again, if you have challenges uploading, please reach out to Haley. Complete the ACES Resiliency Home Visiting Staff Survey when it comes to your inbox. It is really important that all staff complete the survey to get a really good picture of where we stand. Especially since we are in such a developmental collaborative. We would love all the information that we can get. Connect with your QI advisor. If you have questions as you go along, please reach out. If you are not certain who your advisor is, on slide 6 of this presentation was that chart that had all of your team names on it that you checked in on. It also had the faces of your advisors and their names. So reach out to them. And if you're uncertain who it is, even after that, or how to connect with them, please connect with me and I can help you connect with them. Some activity milestones. I like this little slide. It's a snapshot of kind of the overall check-ins for the collaborative. We are in learning session 1, so we can check that one off. Action period 1 begins. So submitting your planning tool updates the 15th of each month and completing the survey when it comes out is part of this piece. Learning session 2 is in May and we'll be in Livonia. At that point, we'll be asking you to share your storyboard from your completed first PDSA cycle. And know that sometimes the closing out of your first cycle does not always exactly happen at that point. Just come to that meeting with enough of your storyboard filled in with the learnings that you have so far. So if you are still in the due stage and you're going to be wrapping up in June, just share the things that you have learned so far. That would be helpful to another team who is thinking about working in this area. And then after the meeting in May, action period 2 begins. And then learning session 3 will happen in September. The location has not yet been finalized. And then the last bar here is the final documentation. So by the end of September, you should have your final documents for each of the cycles. So a final team charter for both cycles and a final storyboard for each cycle up to group site for your final piece for the state. And know that because we have it up in group site this year, it also enables your state level resource people to also look in on your cycles, and they might reach out to you if they are interested or know a resource in the area that you're working on. Because we are virtual this year, post-meeting evaluations are a little bit different. This is the link to go to complete the evaluation for today's opening session and breakout. Something to note, if you are in an LLG team as well that met yesterday, the links are very similar. So make sure you are filling out the one that says LIA FY20 for today. You will also receive the link from Haley after the meeting, and we ask that you have all staff who attended complete the survey. We know that you may be in the room in a group, so we want to make sure that all the staff who were participating today get the chance to complete the survey. And a last thank you. If you have additional questions, reach out to your MPHI coach. They were on slide 6, but they are also here For this collaborative, I am the QI coach for the MD-HHS HFAs. Grace will be coaching the MD-HHS, EHS, and PATs. Shelley has the NFPs, and Jeanette has the 32P sub-4 teams who are participating. So please make sure to connect early and often with your advisors. We're here for you to support you. Do you have any questions before you launch into your work time? And just know that I will be here until 1. Okay, well, I will be here until 1 if your team wants to take some time and starts working on things and want to pop back in with questions. I will be here waiting for you. If you have questions after that point, please connect with your QI advisor. Thank you all. I hope that this was a successful feeling on your end to do this virtually. Take care. If you log off, have a great weekend, and we will see and talk to you going forward.